Hello, everybody. We will be starting shortly. I am Zinga Blake, your moderator. I'm really looking forward to this conversation, so stay tuned.
Hello, I'm Saraswati Vedam. Welcome to today's event. Before we begin, I want to acknowledge that I'm an uninvited guest and am grateful to live and work on the ancestral, traditional, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations. There are many hundreds of people on this call, and those of us in North America acknowledge that the ground beneath all of our feet is the historical home of Indigenous peoples, many of whom have been forced to leave for other lands. And Indigenous peoples are not a people of the past. They are here with us now, continuing to live and work on these lands. I invite those of you who are new to the concept of a land acknowledgement to explore nativeland.ca to learn about the land you are on. Our panelists are joining us today from different regions of the United States, including California, Florida, and New York. I'm sharing with you now a map that indicates the Indigenous territories for where each of today's speakers live and work. I have the honor of introducing Zinga Blake, our moderator today. Ms. Blake is an Emmy Award-winning producer with a specialty in capturing multicultural and underrepresented voices. She has been on both sides of the camera as the first African-American human to host a show on Cartoon Network, in addition to appearing as talent on ABC, Showtime, Current TV, Network 10 Australia TV Guide, and BET. She has also produced for production companies, organizations, and social impact companies, including For Good Entertainment, Causecast, Emergency USA, the United Nations International Labor Organization, and Tribune Media. Ms. Blake is currently the Race and Culture Executive Producer for ABC-owned television stations. Ms. Blake, we are grateful and honored to have you here today to help guide this important conversation about what quality pregnancy and birth care looks like for service users.
Thank you so much, Dr. Vedam. Today, we're here for real talk about safe care in pregnancy and childbirth. This is the launch of the Giving Voice to Mothers report. Dr. Vedam will start us off today with an overview about the study, and then our panel of experts will respond to the findings. I want to start with a little bit of housekeeping though. So we want to hear from you. Join us today in this important conversation. All of the chat from the participants is taking place on Slido. To access Slido, use your phone to scan the QR code on your screen. You can also access the chat by opening a new browser window and entering www.slido.com. Oh, my voice. If you need any tech support during today's call, please let us know in Slido, and we're happy to help. Today's call is closed captioned. ASL interpretation is also available for those who would prefer it. If you have not received the ASL instructions and would like them, please contact Tamar by using your phone to scan the code on the slide. You can also email her directly using the email on screen. First, we will watch this video, which is beautifully narrated by one of our panelists, my colleague and friend, Ms. Tatyana Ali. Ali is a mother, actor, and advocate, and we'll be hearing from her later today as part of our expert panel. Let's listen to what she and other mothers and birthing people have to say about the findings of this report.
Almost 3,000 people from all 50 United States completed a national survey about experiences of pregnancy and birth care. When we were asked to describe the best thing about our care, we said, this is what high-quality pregnancy and birth care looks like. Parents from communities of color and people who gave birth at home or in a birth center worked with midwives, doctors, and community health workers to design the Giving Voice to Mothers study. This study tells the truth about our experiences of pregnancy, birth, prenatal, and newborn care. The findings of this study could transform how care is delivered and who delivers care to those of us who are most in need. This survey is different because it's the first time that racialized people and people who chose community birth have decided what to study, how to ask the questions, and how to tell our stories. We don't see ourselves in most other research. Amplifying our voices is a critical step in reimagining and transforming healthcare. Almost all of us said it was very important to have a trusting relationship with our care providers, have culturally matched care, have providers that understand what we value the most: respect and autonomy.
There was mutual respect between my providers and myself. It made things flow more gracefully. I felt I had the best care I could ever ask for.
Out of 2,700 people who reported on their preferences, more than 90% said it was very important that we lead decisions about care for ourselves and our babies. About 30% of us wanted to consider input from our care providers, but only 26 people said it was not important for us to lead the decisions. And yet, when we reported on who actually led decisions, it was our providers, not us, who made the decisions. At the end of the survey, more than 1,800 people took the time to describe the best and worst things about their care. Here's one example.
The worst thing was being pressured to consent to a procedure that I felt was unnecessary and dangerous if it wasn't medically indicated. I was pressured every time I went for an appointment to schedule a planned C-section.
There were important differences based on where we give birth. We have more control over our decision-making in our own homes or a birth center, but those of us who gave birth inside a hospital report significantly less autonomy. Many of us have no choice when it comes to where we give birth or who takes care of us. The study shows that no matter where we birth, people who have midwifery care report greater respect, higher autonomy, more privacy, and more dignity overall.
I had little to no options. No doula, no birthing centers, no midwives. There was one hospital, and that was it.
Yet Black women were the least likely to have midwifery care. The study shows that access to other birth professionals, such as doulas, also differs by race. We know what we need to have a healthy pregnancy, but for most of the services we knew we needed, no one in the health system helped us to get them. Racialized service users have significantly more unmet need when compared to white women. Black and Indigenous women are 2 to 3 times more likely to have unmet need. It can be hard to hear when people talk about their experiences of not giving consent. But it's important for our voices to be heard. This is what it looks like when people are not included in decisions about their own care.
The doctor who came after I birthed my baby started touching my pelvic area without my knowledge or consent. When I asked what she was doing, she said, "Giving you anesthesia," without further explanation. I asked why, and she said, "Because I have to stitch." I didn't understand. A second later, she said, "Because you tore." I felt violated and not included in my own care of my own body. I did not like the fact that I was injected with things without my knowledge.
1 out of every 6 of us experience mistreatment. Among those of us of color, double, 1 in 3 of us experience mistreatment, including being shouted at, scolded, ignored, or threatened by their providers. The type of care provider we have matters. In this study, about half were cared for by physicians and half by midwives. We found large differences in the amount of autonomy, respect, and mistreatment that we experienced, depending on who cared for us. And place of birth matters. People who gave birth in hospitals reported more mistreatment.
Once I was told I was being transferred, my opinions, my concerns, and really my whole self was ignored, and I did not matter.
About half of us declined to have a test or procedure sometime during our pregnancy or birth. White women were more likely to report their decision to decline was respected, while women of color were twice as likely to be pressured or to have a procedure performed or test against our will. When we had a difference of opinion with our care provider about the right care for ourselves or for our babies, 8 in 10 of us were mistreated. Why does this matter? Studies have shown that when the concerns of pregnant people are ignored, there are delays to care. When we are not treated well, We may not seek care because our trust in the healthcare system is broken. These are critical, missed opportunities to ensure quality and safety for everyone. That's why it's important to listen to our voices. When the findings of our study were taken back to our communities, we stressed the need for more access to the kind of care we want closer to home, more support, and more information. We need you to read this report. Learn more about what to do. Tell others about it. Hear our voices.
Very powerful and very insightful. And as you can tell, putting a voice and a face to data and to statistics is extremely important and impactful. And this really gives me hope that if we listen to the voices of the people who contribute to the study, we can truly transform care. Now, let me formally introduce you now to Dr. Saraswati Vedam. She's the lead investigator at the Birthplace Lab and professor of midwifery in the Faculty of Medicine at the University of British Columbia. Over the past 35 years, she's served as a clinician, educator, researcher, and mother of 4 daughters. Her lab explores experiences of perinatal services among people with identities, circumstances, and backgrounds that are underrepresented in research. Dr. Vedam has coordinated several transdisciplinary and community-led research projects across North America, including the Giving Voice to Mothers study. These studies have led to the development of new tools to measure quality of care.
Are you able to see my screen now?
Yes, we are.
Good morning, everybody. Good afternoon for some of you. I'm going to explain why we are here today. I'm going to tell you the story of this study. This study has been supported by a number of generous foundations over a decade. The multi-stakeholder work began over a decade ago when, in a series of national birth summits, consumers, doctors, midwives, nurses, lawyers, researchers, community health workers, policymakers, community advocates, and insurers met to grapple with their divergent views about what quality and safety mean. We spoke about the barriers to realizing our common ground. We spoke about bodily autonomy, about equitable access to quality care. And we realized that our common ground was valuing person-centered care. We were able to describe 9 action areas that needed attention, but then we realized that we needed to listen more to service users across the system because data was scarce. Well, how do we enhance quality in research? Most people would agree that you have to ask the right questions in the right way, you have to ask the right people and ask enough people. But most survey research until now was really just focused on that last one, asking enough people. Maybe not the right questions. So we asked our community partners. They agreed with us that participatory action research, that method seemed to provide an answer. We first had to put together a steering council where the service users would be the decision makers. We included providers and community health workers, NGOs that served underrepresented populations, and a whole host of other professionals who had a stake in this conversation. We created a team and they helped us seek the funding. We co-created the ways to measure it. They helped the community members and NGOs and everybody helped us to recruit participants. And then we took the findings back to the service users and the community members and the steering council so that they could help us decide what to analyze, how to identify those key messages, and how to tell the story. The community members chose the topics they wanted to study. We knew that they wanted to understand what care options were most important to pregnant families in the US, and how do communities of color experience care? How do families decide where to give birth, and does place of birth affect their experience? How do they experience the process of making decisions, including being heard and treated with respect? Most importantly, they said it was important to understand what builds health and well-being. We started with a broad scan of existing school tools and metrics, And they helped us to select and adapt or design new questions. After we had a draft survey, we went back to the community and we found people who had never seen it before, but people who had lived experience to help us rate each question for relevance, clarity, and importance. And then we went on and had ongoing community consultations through the whole thing while we beta tested, while we decided what the recruitment materials would look like, and all the way through the process. When we created the recruitment poster even, there was a lot of discussion about the image. They said you can't just have someone who looks like a particular ethnicity or race, and you can't have someone who looks very pregnant because people experience loss also. We also discussed where to send it. We thought that we would just work with our community partner who was in New York and who was already engaged with a statewide community-based data collection. They had a lot of connections. But this, again, the service users and our steering council said, no, we can't wait. This is too urgent. We need to send it to our sisters, our neighbors. We need to send it through our methods and through our networks. And so we listened to the community and translated and back translated into Spanish. And in fact, they were right. We got respondents from all 50 states. You can see that it mirrors the population density. They represented a broad range of service users across all kinds of economic contexts. And we deliberately and successfully overrepresented for state racialized people, slightly more than the US Census for Black and Indigenous respondents. An accurate percentage of the US Hispanic Latina population is unknown. In our survey, it was 10%. And we had 3% of the respondents were self-identified as Indigenous, which is larger than what the census categories are. About half in the sample had a planned hospital birth and half gave birth in the community. This was, we were in trying to get those two populations who had not been heard before, communities of color and people who planned community birth. So we understood this was not representative of the whole population, but it allows us certainly to say something because we had such a robust sample. Here's a taste of what was different about the types of questions we asked. They told us that our partners, community partners told us that you can't just look at what we make and what our paycheck is. What about if we have enough money to buy food at the end of the month? What about if we needed food stamps or received housing assistance or needed a subsidy? That you had to look at it in a round way. They also said they always ask us about our neighborhoods and domestic violence, but do they ask us about what about violence against our communities and family members? This is what I worry about every day. And as you can see, it was the Black service users who were most worried and stressed every day. They also said, you can't just ask us what is wrong. What about what really helps and who really helps? We found some validated scales that we had used in previous studies around people's agency and in decision-making, where they could agree or disagree to simple statements that taken together could rate the level of autonomy they had in those conversations and interactions with their providers. We had a similar one on respect, which measured their comfort and their comfort in asking questions, declining options, and whether or not they felt their identity changed their experience of respect. They also said that there are types of mistreatment that they've experienced that they wanted to see what others had. How often is this happening? What about being shouted at, being scolded, having treatment withheld, or being forced to accept treatment? What about when they are ignored, when people refuse to help them or fail to respond to their requests? The data was ready for analysis in early 2018, and we worked with the steering council and community members to prioritize the items to explore and to identify scholars with lived experience to lead the analysis and to make sure we got the interpretation right. And then we decided together who to tell the story to and how. My colleagues and I, the community partners, the other scholars in our team presented over 50 times since 2018 about our initial results. This was after decades of warnings and calls to action. And yet still we find there are very few pragmatic tools to use when adopting these recommendations that the communities have elevated. We published in 2019, this paper has been cited in journal articles 294 times since publication, and the results were featured on all the major networks. We were able to identify, we made a commitment early on that we would only analyze if we had someone with lived experience as a scholar who could help lead the analysis. So we have partners who are all over the country, as you can see, who are amazing scholars who are helping us to tell the story. They're looking at many different aspects about Latinx experiences, about consent, about rights and human rights, about reproductive justice, about racism. And what have they found? We have some that have been published and a lot that's coming. So we know that there's an impact for culturally centered care. We know that non-consented pressure exists, and it exists in a disparate way across race. We've learned about autonomy and respect regionally, and we're learning about how there's differences in what people are offered. We've learned that people who have different body sizes are treated differently, and we've learned about that place of birth and provider matters. We have translated the research for the community, and our partners have now begun to action our vision. So you can go to our digital report to learn about these community-driven solutions, where person-centered care has interacted with our Giving Voice to Mothers study. Thank you.
Thank you so much for that, Dr. Vidam. Clearly what we are learning is that pregnant people receiving care know what matters most to them. And what birthing people are telling us is that there is work to be done to deliver birthing care that is respectful and free from mistreatment. I can't even believe that this is a conversation, but here we are. The good news is that we have brought together a panel of people who can speak to not only the challenges, right, that we're seeing, but most importantly, can speak to the solutions. Let me introduce you to a direct descendant of two of the last granny midwives in Southern Alabama, Dr. Chandra Adams. She believes in integrating the midwifery model of care with modern obstetrics. She is a board-certified physician specializing in obstetrics and gynecology. And at her private practice in Jacksonville, she boasts a labor to cesarean conversion rate between 9 and 11% per year. As a VBAC, which stands for vaginal birth after cesarean, so Dr. Chandra is a VBAC mom of 3 children at home. Dr. Adams is a strong proponent of evidence-based medicine and women's safe choices in labor, with her practice averaging an annual VBAC success rate around 85%. Hello, Dr. Chandra.
Hi, Zinga. Thanks so much for having me. Please call me Sean.
Oh, okay. We're on a first name basis here today. Okay, Sean. Welcome. We're so happy to have you. And we also have Dr. Mimi Niles, who's an assistant professor at NYU Roy Myers College of Nursing. She is a theorist, an educator, a researcher, and a certified nurse midwife. Dr. Niles serves on the NYC Department of Health Maternal Morbidity and Mortality Review Committee and has received various awards, including the Johnson & Johnson Minority Faculty Award. Her work explores the potential of integrated models of midwifery care in creating health equity in historically disenfranchised communities. She hopes to generate midwifery knowledge as a tool to build equity and liberation for marginalized and minoritized people and grow the profession of midwifery globally. Hi. Dr.
Hi, thank you so much. You can call me Mimi as well, please.
Hey. Okay, Mimi, I'm getting more friends today. And we have Nicholas Rubeshkin, who's an associate professor at the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of California, San Francisco, and a practicing obstetrician. He holds a PhD in global health sciences and is in his scholarship and clinical practice, he addresses the provision of evidence-based and respectful maternity care. His recent research explored the ways in which a tool to predict the likelihood of a successful vaginal birth after C-section, again called the VBAC calculator, reproduced racism in American maternity care. Really important work. Hello, Nick. I mean, I assumed I can call you by your first name.
Yes, please. We're having a friendly conversation here. Thank you so much for that introduction. I'm really excited to be on this panel with you all today.
Of course, thank you for being here. Thank you for your time. And next we have Mrs. Jenny Joseph, who is the founder of the National Perinatal Task Force, whose mission is the elimination of racial disparities in maternal child health in the United States. She's a certified professional midwife. Sorry, my gosh, she's a certified professional midwife, and she created the JJ Way, which is an evidence-based maternity care model delivering readily accessible, patient-centered, culturally congruent care to women in areas that she terms maternal toxic zones. I'm just like obsessed with what you're doing. I want to make sure that I'm explaining it very clearly to our audiences. Her focus and drive is to ensure that Black women and other marginalized people remain safe and empowered. She owns and operates a training institute, health clinics, and birthing centers in Orlando, Florida. She's been recognized as a Time Woman of the Year 2022 for her work in promoting perinatal equity. Hello.
Thank you so much. And yes, call me Jenny too. I'm Jenny, JJ, either one.
Oh, wow. Okay, Jenny, JJ. Thanks so much for being here.
Thank you.
And finally, we have Miss Tatyana Ali, best known to millions worldwide for playing Ashley Banks in the iconic comedy series, The Fresh Prince of Bel-Air. What you may not know about Tatyana, though, is that in addition to being a Broadway-trained actress and singer, she's also a producer, Harvard University graduate, and an activist. During the 2008 and 2012 presidential campaigns, she served as a surrogate for President Barack Obama, speaking to communities and young people across the country about voting as an imperative. As part of her journey to advance Black maternal health, she shared her own harrowing journey in an op-ed called Birthright in Essence magazine, which led to her serving as a celebrity counsel advocate for the March of Dimes. She lives in California with her husband, and she brings her perspective as the mother of their two sons to our panel. Thank you so much all for being here. Tatyana, we're actually going to go to you first with the first question. So how do these stories resonate with you?
You know, this work resonates with me in very personal ways. You brought up the piece I did in Essence. Just for context, I experienced obstetric violence with my first son, a very healthy pregnancy, but what happened in the hospital ended up with him being in the NICU for 4 days. And after that, when I was expecting my second son, I decided to go to a different way. I decided to work with a midwife. So every single aspect of this study, I feel that even now, there's I'm like, check, that happened. There's a very kind of validating nature to this study, to hearing these voices. And as a performer, you know, I narrated that video, and there's a choral nature to the findings. This just large chorus of birthing people sharing their experience, and so much of it is, there's so many similarities. So many people are saying the same things. My hope is that, you know, especially after the week that we've had, my hope is that that choir is so loud that people actually start to listen and pay attention to what's happening. I also find it personally empowering, and it just objectively is, that the authority and the decision making, even in making the study, is with the community and the birthing people, the exact thing that's missing in so many birth spaces. I think that's so poetic and profound, so that we're not just studying people, we're listening to what people need and want.
Oh my God, so spot on. And that's actually very critical in just storytelling all around. We have to empower people to tell their own stories. We cannot tell them for them, right? We can't tell their stories for them. And you brought up obstetric violence, which that's just so mind boggling. And so, as a practicing obstetrician, Shan, what does this report tell us about how clinicians can improve access to respectful, high quality care? But before you even get into that, I kind of want audiences to understand, what is obstetric violence?
Tatyana, did you want to define obstetric violence?
It's better described by you. That's a term that allows me to I was I only know how to define it in my terms, in the terms of my story, being touched aggressively, being shouted at, being yelled at, being hurt physically during my birth, being coerced. I think that's emotionally violent. For me, that obstetric violence is really an umbrella term for everything that I experience, for me. But I know that that's maybe not as the scientific term.
No, that's your definition, and I think that that's what this is about. As the obstetrician, I can't define what obstetric violence is. It has to be defined by the person upon whom it was perpetrated, and so that's why I put the ball back in your court. Because when you say I experienced this, then you own that term, and you have the right to say what that means to you, and that's what it is, because you create that definition. So to answer your question, Zinga, just what does this mean in terms of high quality care? I think we first have to look back at, what does high quality care really mean? As practicing obstetricians and as a hospital-based physician, what we are taught about quality is what passes through your QA, quality assurance and quality improvement committees. And those are outcome-based. It's how many adverse events do you have? And the results are driven by percentages and numbers. They give us metrics. You have 80%, you have to stay below 80% of this, and you have to reach above 24% of this. And there are charts in every nurses break room. If there are nurses on the call now, you know exactly what I mean. It's how many times did this happen, and how many different ways can we, and it's not even really how do you get to the answer, it's just don't let that happen. And so if every day all you hear is people can't have this, and people can't have that, and people can't have that, then you're continuously trying to figure out, what interventions can I use to keep my name off of that chart? I don't want to end up with a patient who has this outcome or that outcome, and in the hospital doesn't necessarily add in the emotional aspect of it in interpreting those results. There's the carrot and there's the stick. And with the people who might not reach those numbers and those metrics, it's all sticks. They tried to introduce Press-Ganey scores for physicians, which is the survey that's sent out to patients. How did you feel about your care? Did you like this? Did you like that? And ever since hospitals have been marketing direct to consumer, come to our hospital for this, come to our hospital for that. I mean, that's crazy. You go to a hospital because you're sick and you expect to just be taken care of, right? Because you're sick, it's a hospital. But no, come to our hospital because we'll be nice to you. And if you don't think that we were nice to you, we'll send out a survey. And if this doctor gets bad scores on the survey, we're going to take away part of their pay. But there's no how do you fix it. There are no specific metrics as to what is happening, and that's why having the patients, having the birthing people define what is violence, what is disrespectful care, what is low quality care, is such an important additive that's missing to helping us not only make the correct definitions, but try to find some reasonable solutions for it.
I would love others to jump in too on this conversation to provide your own perspective on this. Who would like to jump in?
I'll jump right in. I think that it's so important here. I mean, it's like a hashtag, it's time to tell the truth. This study, for the first time, I think, opens up an opportunity for us to hear and to understand the truth. This is what's going on. This isn't something that has been made up. And like Tatyana says, it's a very common thread throughout all birthing people in the United States of America. And it's borne out by the wretched and horrendous outcomes that we have that have us be dead last in developed nations as far as maternal deaths, maternal morbidity, sickness, disability, harm, just from having gone through a maternity cycle. There is something very wrong when the level of harm and disrespect, pain, outcome, and death is as a direct result of the system that is perpetrating that and perpetuating that, and is essentially condoned in that way. So with the voices coming forward like this, we can now take this information and work our quality assurance from a different approach, because what we've been doing has not created quality at all and has not documented any pathway to getting there.
Yeah, I think I would add to that within the system, there are no accountability methods, right? There's really, I'm a provider in a big public hospital system. Besides the metrics that Dr. Adams is mentioning, which are sort of these internal empirics, there are no metrics that measure the things we call the softer things, which I take a little bit of issue with because they're hard to do. It's hard, it shouldn't be, but in a system that does perpetrate violence, it's hard to hold people and their families and their culture and their values at the center because the system doesn't value those same things, right? And so this kind of research will help to produce the necessary metrics. The next level of action is, will the systems then respond, be responsive, adapt their metrics to capture the softer, the humanized, the love, the compassion that people deserve and are starting to demand. I mean, we're in a moment right now where we're talking about autonomy. It's become like a word that I didn't think people would be using on a regular basis, but it's so important. It carries across the reproductive lifespan. It's not just in abortion. This study shows that it's happening in the labor room. It's happening in the birth room. It's happening on your postpartum visit. It's happening in your prenatal visit. Your autonomy does not matter in the current system. So what do we need to do to center people's autonomy, to center how that care is delivered, not just what care is delivered, right? Because that's what we measure, the what of the care, but how do we measure the how of the care? It's harder, it's messier, it's not as numeric, but we can do it. And this study shows that we can do it.
I'd love to hear from you, Nicholas.
Yeah, I actually wanted to go back to a little bit of this term, this specific term, obstetric violence that Tatyana referred to. It's become a really powerful way to name the experience of really a new form of discrimination that women and birthing individuals are experiencing in childbirth around the world. It was a term first coined in several Latin American countries and is now actually a legal term, a legal concept in those countries where laws have been passed to try to address this form of discrimination in childbirth. And in fact, the forms of mistreatment, the experiences that the Giving Voice to Mothers study measured are really very universal, that there's enough evidence globally that this unfortunately happens to women around the world. And in fact, in 2019, in a landmark report, the United Nations assessed the weight of this phenomenon globally and named this new form of discrimination as a form of violence against women, as obstetric violence, and actually opened up new avenues for international human rights monitoring and accountability for obstetric violence.
Wow, that is incredible. So you know, over the past 2 years, we've uncovered a lot of inequalities in the healthcare system, right? Brought on by the global pandemic. And it's just now a part of the national conversations, I think, around the world, but specifically in the United States, we always talk about health quality or equality overall. But there is an aspect that we really need to unpack even further, which is equity. And we need to define that. So, why does equity matter? And first of all, I think we have to, for our audiences that might not be familiar with what health equity is, if you could define what health equity is, and then let's talk about why it matters. Mimi, I'm going to send this one off to you.
Sure. You gave me the hard one, but I'm happy to try to answer this. So health equity, which is different than equality, which is a word that you mentioned, health equity is the concept that the way we distribute resources needs to meet people's needs. So the idea that everybody gets an equal amount of something is not helpful to people who've been historically or generationally disenfranchised from access to those resources. So equity is this essential concept that the distribution of resources, the distribution of services, the intentionality around quality has to be distributed based on the needs of people, based on the needs of the community, and acknowledging the inherent disenfranchisement, the inherent inequality, the inherent and sort of built oppression that many communities, particularly Black, Indigenous, immigrant, queer communities experience through and across the generations, particularly here in the US. So that's how I would define equity. I welcome all the panelists to contribute to that. And I just want to say it matters because it doesn't exist. That is the truth of American healthcare. And as Nick is saying, global health really is that we need equity because it doesn't exist. The idea that we are all the same or that we have equal protections, I think it's very clearly being shown that we don't, right? People have privileged access to healthcare. Money, capital will buy you the needs that you have, especially in this country where it's privatized, predominantly privatized healthcare, right? It's fee-for-service healthcare. You have money, you can get the kind of care that you need, basically. So we, in this country, I think really need to start, and I'm going to use Jenny's term, really need to start understanding the systemic issues that are in place, because for so long, mothers get blamed for all the inequity. She didn't go to healthcare. They didn't take their prenatal vitamins. They didn't show up. They didn't do what we told them to do. They used drugs. Whatever it may be, the blame has been placed on the childbearing person. The system has gotten off scotch-free, no responsibility. And that needs to end, because this report shows us that people are telling us that there is violence in their communities, there is violence in their neighborhoods, there is violence in the birth room, where they give birth. So people who gave birth at home, people who give birth in birth centers, have very different experiences than people who give birth in the hospital. So let's start and turn that magnifying glass, for me it would be a mirror, because I work in one of those systems, and start understanding what are the system level factors that prevent people from being truly liberated and prevent people from reaching their own highest standard of health and well-being.
Could I
Go ahead.
add something?
Absolutely.
That idea of the birth person being blamed, I'm an advocate. I'm not a doctor. I'm somebody who experienced something. And that's still taking place. I mean, even with what we know, the information that's being given to birthing people is to arm them so that they can somehow during labor make all the right decisions that they need to make so that they're protected. It's impossible to protect yourself when you're in an incredibly vulnerable situation like labor and pregnancy. Also, and this is happening a lot in the media right now as well, when we're talking about racialized people, we're talking about Black and brown people being hit the hardest by what's happening in the Supreme Court. And right now, I just, because I think this is kind of my place here on this panel, just to say that like the trauma, that the experiences that are being delivered to people right now never goes away. You know, it's something that it has long lasting impact on the person's life, on their family life, on their ability to parent. My son is, you know, 5, he's about to be 6 years old, and I'm shaking just hearing, just in this conversation now, and I do these conversations a lot. So that trauma that's being put on people, it's not just that moment. It's not just, it does not just affect the person the moment it happens. It affects them the rest of their lives. It's something they now have to live with.
Tatyana, I thank you so much for naming it in that way and making it so clear and plain. I think we need to really, at this juncture, recognize that in order to get to equity, in order to get to every person every time having their needs met, we have to recognize the historical and the generational harms and the structural way that we set this up in the first place. We aren't here by accident, and this is not sustained and maintained by accident. So the continuation throughout the generational lines of the trauma that you've just described so eloquently, it lives on and it continues to impact physiological outcomes. That's the part that I really want to stress here. As we listen to the voices of these women and these people who have spoken their truth, we also have to recognize that on the other side of it, these are the ones that survived. That there is actually an outcome in the United States right now that could end in death because of these deep historical, structural, institutional harms, the racism, the classism, the sexism that is deeply embedded in all and everything we do in the United States, plays out in maternal child health through this morbidity and mortality that we keep adding up the numbers and churning them out every year and throwing our hands up and saying we don't know. It's time for us to know because it's in plain sight. And if we listen, we can change it.
So what happens though, because this happens a lot, right? When political leaders say, well, this doesn't exist. There's no such thing as systemic issues.
They're lying.
But I hear people like, so as clinicians in this field, what do you all do now to address that? Because that is a huge barrier to creating change. If the people who are in positions to actually make that change are just like, no, that's not true. Doesn't exist.
I'm going to tell you a story. Excuse me. I'll tell you a story. You know, we learn in med school that this is a risk factor for that. If you've had 5 or more babies, you're at risk for postpartum hemorrhage. If you had high blood pressure prior to pregnancy, you're at risk for preeclampsia. You need to treat being African American as a risk factor for death from. And all we say is increased likelihood of death, increased likelihood of death. And in doing that, we do a couple of things. We have our intended goal of raising awareness and, you know, having us know that we need to demand that we're listened to and that we're heard. But we also play a part in stealing the joy of African American women during their pregnancies. And in my practice, they seek me out because I look like them. And in the study, we said that, you know, having care from someone who looks like you matters. And they come to me because they say, you know, I know you'll take care of me. You look like my cousin, you know, and I tell them absolutely. And I say, now, before we go on, let me tell you the 2 things that are killing us in labor and delivery. It's high blood pressure and it's hemorrhage. It's not a boogeyman. It's not an unnamed diagnosis. You just walk in a hospital and boom, you're Black, you're zapped and you're dead. No, these are the 2 things that we're going to be looking out for. Is your blood pressure going up? If it's going up, you're not going to fight with me about why it's going up, right? You're going to know that I am recognizing this as an important sign. I'm not going to send you home. You're going to be angry with me about not sending you home before I send you home, and I'm not comfortable that you're going to be safe when I send you home. And they know that going in because we have those conversations before we're in the hospital. We talk about it repeatedly. And I still emphasize the joy of being pregnant, of caring, of growing your family too. But I tell them, I'm going to take care of you, and they feel safe. And even though everyone in my practice who's providing that care does not look like them, they know that they are in a culturally competent place that practices the type of care that will stop and say, hey, is your interpretation of what's going on, is it what we're trying to relay to you? Are you feeling afraid because you think that this outcome is happening to you, and that's why you are reacting to us in this way? And we stop and we have a conversation, and we've saved lives because of it. Women have gone home and they've said, wait a minute, the midwife told me that if I feel this way, I need to check my blood pressure and I need to go back to the hospital. And they said that I'm not supposed to leave the hospital until they call my doctor and run it by them. They say, if I'm bleeding this much, I'm supposed to go back to the hospital. I'm not supposed to just wait until the morning and see if it gets better. And if people know that there's going to be somebody on the other end that's paying attention to them and that's listening to them, they will seek access to care and they will help you. They will play a role in helping you to save yourself. If we give everybody access to this terrible system, that doesn't improve anything. We have to improve the system.
And that, I guess, falls under the human right conversation, right? Access to this kind of care is a human right, right? And Nick, you serve on the board of the international nonprofit Human Rights in Childbirth. So can you tell us your perspective on what lessons there are to be learned from the report with regard to human rights?
Yeah, in my role in the international nonprofit and as an obstetrician in this space, I've had the privilege of giving expert testimony in actual court cases where women and families who have been physically and psychologically injured as a result of mistreatment and abuse during childbirth are seeking legal remedies for those injuries. And I think that looking at patterns across these cases, that the women and families who are standing up and realizing that their rights have been violated are seeing a couple things. They are seeing that they're really alone, that this is a really still a very new area, and this study really helps to highlight and bring community, show that they're not alone in this phenomenon. And that also it's just really, it's very hard, as Mimi was saying, that the existing accountability mechanisms are failing people. And that even includes, there are very few lawyers who understand this area and can argue these cases, for instance. So what I see from a human rights perspective, though, is still hope that that this can really ultimately bring us together. I think of human rights as not just for lawyers, that we all possess human rights by the fact of our existence, and we all have a human right to bodily autonomy, to care that optimizes our spiritual and emotional and health and spiritual, emotional, and physical well-being. And that I'm hopeful that through supporting fundamental human rights, which we can all access without having to go through a court system, that can be an antidote to this mistreatment that we're all witnessing.
Anybody else want to weigh in on that? No?
I mean, I think, the other question that you asked around like what's the provider's role, is that this is not a core part of our training, right? This sort of couching our work within a human rights framework or a reproductive justice framework, which is sort of a child of the human rights movement, is not something that is taught to us across the board. Those of us who are on this panel sought that out for ourselves. It's additional work, it's ongoing work, it's never ending work. We have to almost unlearn what we've been taught, like Dr. Adams was saying about, the risk factor approach or the algorithmic approach. Yes, it's valuable and it's necessary because pregnancy is also a physiologic process that pathology can come into that process. But these kind of social principles and spiritual values and cultural ideas and sociology and anthropology and all those kind of other sciences that we think about, the social sciences, that's not a core part of our training. And I really think that it has to begin there. The way we are taught as providers, that includes physicians, that includes midwives, that includes nurses and dentists, and the whole spectrum of those of us who provide care. We need to learn not just the language and the rhetoric, because anyone can sort of spout out the right words. Autonomy, what does autonomy mean? I ask my students, let's talk about it. I want you to, let's define it. What does it mean? What does it mean in your own body? And what does it mean as a service provider, right? So those are sort of the things that I think about as providers. We are also impacted by the system. I try to remind people that the system breaks us as well in a certain way. And that within the obstetrical system, and I say this as a midwife, there is a power dynamic. There is a hierarchy of practice, right? The physicians are on top and then everybody else, right? And so if the physician care model is rooted in, I'm right, that, this is the problem, this is the pathology, this is the risk factor, what you need, what you value, what you want, what's important to you, what's your culture, I'm not going to factor that into this care management plan. That is a problem. We don't talk about it enough, but we need to start actively talking about it.
And I think what's important is arguing about things that matter too. I think when people come to my practice, they know I'm not going to argue about things that don't matter. You want to buy a gown off of Etsy that has your name embroidered on. I don't care if you don't wear the hospital gown. That is no danger to your life. You can labor in different positions, deliver, walk around. I don't care. Like I tell them what things are harmful, and they know that those are the things, like that's why they come to me. They come to me so that the things that are harmful don't harm them. They don't want to manage their own blood pressure. They don't want to call pharmacy and order their own labetalol or hydralazine or nifedipine or whatever. They don't want to do that. They want to get in and out of the shower. They want to get on their hands and knees. They want to sit on a birth ball. Those things are not harmful. And we have to stop telling people that walking around with your water broken is harmful. Like that's you're wasting time and you're making them feel like they can't contribute anything meaningful to this experience. Labor and delivery is supposed to feel like something you're doing. It's not supposed to feel like something that's being done to you. Like pregnancy is a normal physiologic event. It doesn't need to be managed. Active management of labor. If there's no medical issue with the mother or the baby, stop it. Put your hands away. Go have lunch. It's okay. You don't have to touch her. She's going to have the baby. There are no other specialties where if you don't get to the room on time, the thing will happen without you. Sometimes if you don't get to the labor delivery room on time, the baby comes out anyway. That doesn't happen to general surgeons. The appendix doesn't take itself out if you don't get to the OR on time. It's a physiologic process. And sometimes we take certain parts of it and over medicalize it and make it just too much. And we lose respect in those times when people actually should be paying attention.
Can I ask you guys a question? Because so for my second baby, we were for my baby Alejandro, I planned a home birth. He went lateral, so I ended up, we went to our B plan. UCSF, Nick, you guys were amazing. It was a completely different experience, but there was static with my midwife. So in this report, if it says that community models of care are working, or that there is a better experience for people, then why are the two why is this unable to work together? I went in with my midwife. I saw that there was like a little bit of she knew how to handle it, but it wasn't like, oh, care provider. Let's work. This is what I know about her. This is what I'm bringing you. Let's continue what is that static? And if we know that something's working, then why can't those modalities, I'm a layperson if I use a word jargon wrong, why can't that be brought into the hospital space as a means to give people better care? Like what is the problem?
I'm just going to jump right in and say what the problem is. I can't help myself. Excuse me. Sorry. The problem is that's not what we want. It's a power dynamic. It's about power. Okay. And unfortunately, it's also about race, because midwifery, no matter how we slice it in the United States, historically, the Black midwives, the African midwives during enslavement, the Black midwives during Jim Crow, and onwards, the Indigenous midwives, their power has been taken away because of the need for obstetricians to have control over obstetrics in the United States. It is about capitalism. It is about systems. It's about institutions. Midwifery is not respected. We've come a long way, but we are nowhere near there, because the rest of the entire world, midwifery is the model to take care of most childbearing people, and is incorporated, and there's a collaboration that is embedded into all midwifery systems around the rest of the world. Midwifery needs hospitals, physicians, obstetricians, maternal fetal medicine doctors, because midwifery has a scope of practice. The minute it changes outside of the normal, we must collaborate. That's where the safety is embedded. But the other thing about midwifery is that it actually centers patients, families, communities by its very nature. And that's anathema to what the system that we have right now is looking for. When we talk about patient-centered care, we still want to have control around that. So when we were talking just now about human rights and talking about how all of us technically are not feeling like that we are having our human rights respected or heard, in the American system, we have a difficult dilemma, because we have this power dynamic that says, no, that's not what we're trying to achieve. We're not looking for the equity for provider to provider. We're not looking for the equity between money, financial, insurance, or whatever, and non. We're not looking for equity in these deeply structural places. But the historical approach to what we do has us keep nurses, nurse practitioners, midwives, physician assistants under physicians. And I feel many physicians, not most of them, are also struggling with that, because they are dealing with a horrendous sense of moral injury, frustration, and pain inside of knowing that they're trying to perpetuate a system that is broken and don't really know how to get out of it. So I know that was a long road around that, but at the end of the day, the reason you felt that tension, friction, and disconnect with your midwife during that transfer was because of all these other reasons and nothing to do with you. And that's what's wrong. Because if everybody in that room and in that environment would send to you, there is no time or space for any of this nonsense. It's just, let's get it done. Let's move to the next step that is the best for this woman, this person who is in front of us right now, who deserves to be in the center, because that's her human right.
Well, I have another question for you, Jenny, because let's get back to the study in terms of mothers and birthing people who worked hand in hand with these clinicians, with leaders in the community, with researchers to design the study. And it presents what they think about what respectful care looks like, what mistreatment looks like, and what they want to see happen to address our maternity care crisis. Why is the way the study was done important? And why are the findings important to those who plan how our, to your point again, system works?
It's so, finally, it brings a sense of, we have taken on a different approach where we've never ever listened with any intention or any sense of we will do something with this information. This study, for the first time, centers the mother, the person, the family. And as they've explained what they're looking for, none of us are surprised. Who could be horrified at the results of the study? This is what you want for yourself. This is what you want for your family member. This is what you've always wanted. Everyone who's been through COVID and has had horrendous experiences with their family members or lost people, they know what I'm talking about. This study puts it down in plain sight. It quantifies it. It points out how very similar we all are. All we're looking for is to be treated with respect, our dignity to be maintained, and our health to be taken care of. It's not too much to ask. And when we were doing our research, and our clinics were involved in, many of our patients and clients were contributors to the study and to these results. they were able to say these things and say, not where I am, because I don't have to deal with that. I'm speaking to if I was somewhere else, just like Dr. Chandra says, if they were somewhere else, they wouldn't be getting what she's offering them. But unfortunately, there are so few of us. So what the system needs is to recognize the power of this type of intervention being health normal, treating people well, treating people right, listening. This intervention, which costs no money at all, by the way, is the simplest and most direct route to changing this very broken system. We take care of every person who presents. No one is turned away. That is our way of operating at Common Sense Childbirth. We make sure that we sit and listen first before we start poking, prodding, and getting on their nerves. Then we also try to help them navigate when they say what they need, because they cannot be left alone to figure it out, because no one can understand it, including the professionals. And then lastly, we support their empowerment and their self-determination. And oddly enough, that physiological change shows up. The cervix locks tight, the baby stays in the body, the breastfeeding is easy, the preeclampsia doesn't present. All of these things happen from just these simple interventions, just listening, understanding, respecting, explaining, sharing. I mean, it's just beyond belief that we're making it so complicated. Listen, everybody's telling us what needs to be said. We just need to get on with it.
I'll just add to piggyback off of what Jenny was saying with the friction between transferring in from home to the physicians. There's a long history behind that for obstetricians as well, because not everyone knows when to transfer. And there are some obstetricians who are traumatized by getting near-death transfers from someone who should have been in the hospital a long time ago and having to clean it up. And then at the end of cleaning it up, because you're being introduced at the last hour of the person who has to do all the things because you are a near-death transfer. And then at the end, they say the appreciation and the gratitude is, thank goodness I was transferred to the hospital. My midwife saved my life. And you're standing there as the obstetrician, like, I kind of did something a little bit. And it built, if you've never seen an out of hospital birth, 2, if you don't have any relationship with anyone who does out of hospital births, and 3, if you don't understand what a midwife does, and you don't really believe in understanding the physiology of obstetrics and how a baby will just come out, then it's very difficult to reconcile that a baby can actually come out without all your paperwork and your lines and your IVs and your monitors beeping and all of those things. And so anybody who's doing it away from all of that must be doing something crazy. And so when they bring them to you and everything has gone wrong, it's because they were trying to do it outside, but it's not. It isn't, because we all know bad things happen in the hospital too. And so the friction between the hospital community and the out-of-hospital birth community has been going on for a long time. And I think we probably need to address that before we can actually, like Jenny says, center the patient.
And I just want to build on that a little bit, because it's a system issue, right? If we had an integrated system where midwives who can offer our services at home, we can offer our services in a birth center, or we can offer our services in a hospital, that we're able to work across the spectrum of care settings. Because this study showed that people who choose to give birth with midwives outside of the hospital institution, they do better in terms of their respect scores, their autonomy scores, their lower mistreatment experiences. So how do we build the system so that if Jenny has to transfer, that is a smooth transfer? There is a mechanism for that transfer. As Dr. Adams said, most physicians have never seen a physiologic birth from beginning to end. It's not an essential part of their training, right? And so we have in this country, essentially surgeons who are caring for a normal physiologic process. They have this amazing specialty. They are surgical specialists, and they're taking care of people who are predominantly having physiologic events. And so there's a kind of an overuse of the surgery because they're surgeons. That's what they do, and they do so well. But I think the core issue is of course, there are transfers that happen, but why did that transfer have to happen that way? Because that midwife knows that when they come into the system, like Tatyana said, they're going to experience hostility, and that hostility is going to be felt by their client. It is. It's a sort of a closed emotional psychological system. I've seen it. We accept a lot of transfers from the community, and until we have smooth, integrated, codified, mandated transfers like they do in other countries, we're going to keep seeing this problem, because again, it's two different value systems. That's how I see it. Two different value systems and two different centers of power. Outside of the hospital, the center of power is the person and their family. Inside the hospital, the center of power is the physician and that care team. And that, how do you reconcile that? That to me is the core question.
As a service user, I know that you feel like you have an either or in terms of those value systems. There's some individuals who would feel safer in a hospital just in case, but to have to make those choices seems so unfair. Why can't we have all the things?
Well, that was.
I know that sounds so silly, but it's I want all the things.
Well, that's okay. And
I want my sisters to have all the things.
Exactly. That leads to my next question, which is actually for you, Tatyana. So where do we go from here? Where would you like to see it go from here?
I'm sharing this video with every single person I know. Birthing person, plan to be birthing person, brother of birthing person, sister of birthing person. I'm sending this video to everyone I know because this report makes things so plain. I've watched this report with my husband, watched as we were editing the video again and again, because like I said, it's just so validating to our own experience. But share it, share it, share it. Even having this conversation, one of the things that I have in common with people who were surveyed is that I have lost trust in I seek more community-based services for all of my reproductive health now because of my experience. Having this conversation makes me think maybe even in my advocacy, I'm telling people, community-based care, that's what's safe now until these transitions happen and until the change really happens. And I would love the experience, the care, the consideration that I had with my midwife. I want that care for all of us, because it doesn't matter how your birth ends up happening. Babies come into the world as they come, whether you planned a C-section or you didn't want a C-section, things happen. But to have that care, my hope is that obviously that we all have it, and I know this report is going to do incredible work towards that.
I sure hope so. And, I know just for the sake of time, I want to make sure that we make this an inclusive conversation and allow our audiences to chime in as well. We want to open up things for questions. As a reminder, today we're using Slido. If you haven't, accessed it yet, you can access Slido by scanning the QR code on the screen. If we can have that screen pop up, see that QR code, please scan that. And using your phone, you can also access Slido on your computer by using the website and code on the screen. So let's look at the first, hold on a second. Let's look at the first one that's coming up on my screen here, which is great. I think this is a fantastic question, honestly. From a provider's perspective, what incentives, consequences, accountabilities can hospitals or insurance companies implement to change the nature of maternal care in the United States? Any of the providers here, who wants to chime in on this one?
Well, I think some of the most exciting and impactful solutions are coming from Black women-led organizations, to be honest. The work of, and I think of a lot of those solutions around the themes of transparency and accountability. For instance, Kimberly Seals Ehlers is a journalist who's created an app, sort of a Yelp, if you will, for hospitals to for women, specifically women of color, to review their experiences in similar ways to this study has tried to quantify those experiences and making those experiences available so people can make more informed choices about where they're giving birth.
Fantastic. Anybody else want to chime in? Providers, accountability. How do we get there? What can?
I think that we have really got an opportunity to look at this from a place of, you know, as we build more power into the people who are in the birthing world, that they get to, just like Nick said, use their own empowerment to choose and to, you know, at the end of the day, you know, it's like any marketing. Eventually, we're going to have hospitals, providers where folk are going to be like, no, not that one. And, you know, there's going to then be a need to, okay, we have to do something different because we're losing the public's trust. And it's about, you know, business at the end of the day. So that will make some difference. The other piece, though, is also knowing that there are other types of providers and being willing and able to embrace them and collaborate with them so that the general public feels that there is this effort to work together rather than to maintain these silos and these power dynamics that have been set up for so long. So we know that there are other community-based providers, perinatal providers like doulas, childbirth educators, lactation educators, community health workers, and midwives, of course, that are standing and already on the front lines who, if we could work together with the larger institutions, be supported, reimbursed, let me put that out there too, recognized and educated. We need support for our schools, we need support for our training, we need all of the other things that, you know, have happened along the way in the medical side of things to come now into and to incorporate the community, not just the voices, but the actual action that will translate into health and well-being and may actually change these statistics once and for all.
And can someone actually speak to the best practice guidelines and the solutions and strategies like anti-racism courses and models of care described by, you know, the study participants?
Sure. I attended a historically Black college and university for medical school. And so part of our curriculum was understanding some of the cultural differences in how families gather for events that occur in the hospital, and just in how thoughtfully planning everything from how buildings are engineered. If someone has to come to the hospital in the Latina community, you need more parking spaces because everybody's going to come to the hospital and make sure that they are okay. Down to things like offering cold versus hot drinks to patients who are of Asian descent, and just things that you wouldn't think of as, you know, but that we can. And if we do, it shows that we're trying to build a bridge. And having hospitals be open and receptive to that, because, you know, the buzzwords of diversity and inclusion and all of those things, people think that just means hiring more providers who are of color. That's a good start, but that's not the end of it, because not everybody's going to have the same experience when they come in and have that same nurse. We can't make that one nurse work all the shifts and take all of the patients of color. But everyone there has to have an understanding of trying to meet people where they are and assess and meet their cultural needs.
And Nick, do you have any follow-ups to that?
Yeah, I wanted to also, as we're kind of thinking about best practices and solutions, just to kind of tie some things together that, as you know, Jenny had previously referred to and laid out so well, that the maternity care system that we're dealing with in the present in the United States, that, you know, as a result of historical processes of racism and sexism and professional hierarchy, that, you know, we have a system that's very obstetrician hospital technology focused rather than community midwife and relationship focused. And that sets up, some significant challenges, particularly for people who are transferring in from home and community and birth center settings into the hospital. Luckily, though, as part of this community-driven process, as part of this study, people have really offered a set of best practices, which you can find on the Birthplace Lab site, to implement now to support quality and safe transfer into the hospital from community birth setting. And I think really the theme for all of that is to really flatten these professional hierarchies and to integrate everybody into the care team. And I think people in the study really valued, for instance, having their midwife who was with them in a community setting be able to accompany them into the hospital and be treated as part of the care team.
I think the other part of the study that should be highlighted too is that people had a hard time finding midwives, right? They also, the challenge was locating a midwifery provider. In this country, about 10 to 12% of births are attended by midwives. That's a significantly low figure, right? And so part of that problem is building a workforce. To build a midwifery workforce takes significant investment and time, right? We have serious training in the work that we do. 2 to 4 years, sometimes 6 years, it takes us to become a midwife, to enter into this profession. We need significant and equity-based reimbursements. We are not reimbursed fairly. Let's be honest about this. You probably have this, Jenny, I don't know, but friends who are like, I can't find a midwife who's in network. That should not be the case. That's not equitable access to midwifery. And Black people in this study said they had an even harder time finding midwifery care, so that we know that midwives are sort of in zones or they're in communities that people don't have access to. And the other issue too, I think, is access to community birth. What does that mean? That means people who want to stay in their home to receive their care, and people who want to go to birth centers. There are not enough midwifery-led birth centers in the United States. I will tell you, in New York State, just up until recently, only a physician could own and operate a birth center. A birth center is like telling a pizza maker that they can't own a pizzeria, is like telling a midwife they can't own a midwifery birth center. So there are no birth centers in New York because midwives couldn't open them. So the oppressions and the restrictions happen at multiple levels. They're not just bedside to patient, right? We tend to focus on that provider to patient. How do we eliminate those oppressions? But these oppressions are deep. They are embedded into our sort of legal system, our legislators, our legislative systems. There are so many archaic laws in the books that are anti-midwife because they were, written in the 1800s to sort of build this sort of physician capital marketplace. And so those are things I think we need to start to agitate against. Demand that your insurer cover your services for midwives, demand your legislator open up midwifery birth center laws, and make them expansive and inclusive, and invest in sort of these maternity toxic areas. That's where we need to be opening up birth centers and training people from the community. Let's give them scholarships, full scholarships to become midwives. We have a doula pipeline that I feel like we don't sort of tap into. The doula workforce is growing. Let's tap into and invest in those doulas who want to become midwives, because it's there. It's just, we need the money and the time and the resource.
Well, and also the information, because I'll tell you this much, that wasn't even an option for me. Like, I didn't even know that a midwife was an option for me. And then I actually had my child in England. That was the first, they assigned me a midwife like right away. And I was like, oh, that's amazing. Right. And so I started this journey. So it's really interesting that information is also key. I don't think a lot of people in this country realize that is, they have access to that. I'm sorry, Dr. Chanu, did you want to chime in?
Yes, because I wanted to say just supporting providers who support a midwifery model. So it's not necessarily just obstetrician versus midwife, because if you have obstetricians who support a midwifery model, that's the beginning of integrating those two systems together. Because I'll tell you, as a medical director of a birth center too, they didn't look at me and say, oh, you're a doctor, so you can absolutely have all the insurance contracts and do all the midwifery things at a birth center too. They said that's not a hospital birth. Your insurance company would rather pay a physician $5,000 and a hospital $7,000 and a neonatologist $2,000 versus paying a midwife $4,000 or $6,000 to do the same thing out of the hospital, whether or not a physician is involved.
So I want to piggyback on there and just mention that we also need to be cognizant of the onus for these changes have to come from us as the providers, as the institutions, as the structure that's already there. Like that's our work to do, because otherwise, once again, we can end up putting it right back on the consumer, the service user, and have it be their problem to fix. These solutions are here now because we hear them. This study allows us to hear these voices, and then for us to take on the responsibility then of helping bring these changes in answer to their concerns and their, their shared experience. We know that we are the ones that have to figure out, how do we all get along? How do we break down the silo? What type of training, what type of updating do we need to do to be able to accommodate these requests essentially from people who are experiencing harm because we just don't want to do that. It's time to do that because we're able and we have enough power as we build out this movement. We consider in our work in Common Sense Childbirth, we're looking at this from a place of we are birthing a more just and loving world. We don't know what else to do, because how else would you break down these structures and rebuild them to match what people are saying they desperately need, and that it's their human rights to have.
Absolutely. And I could sit here and speak to you all day about this. This is an important conversation. This is just the beginning. It doesn't end here. It begins with everybody. Again, if you're anything like me, you're feeling called to take action right now, right? And I think Tatyana said it well at the end of the video. We need you to read this report. We need you to learn more about what to do. We need you to tell others about it because we need you to hear our voices. Storytelling is imperative. Information is imperative. So the full report, along with the resources for taking action, can all be found on the website here at the Birthplace Lab. I want to thank our audiences for joining us, and especially really thank our panelists for sharing their wisdom and their time. And Tatyana, you being so incredibly vulnerable to share your experience with us. Thank you, thank you. And thank the study participants for sharing their voices. I'm Zinga Blake, and we'll see you next time.